Thank you all for having me. I want to thank the organizers and Dr. Evidente for inviting me today to speak to you about this topic of atypical Parkinsonism. Many people often are told, you have Parkinsonism, but we're not sure it's Parkinson's disease. So I want to take some time tonight to try and help you understand what we mean when we just bring this topic up and how we as the neurologists will come to a diagnosis of atypical Parkinsonism and sometimes end up with something else. So the first term, Parkinsonism, is what we're going to start with. So I'm just going to kind of help you understand what we mean as doctors when we use that term. And then what are the conditions that fall into that realm of atypical Parkinsonism, and how do we diagnose those? Also, we'll touch on what to expect with some of the more common types. Again, there's a broad topic, so it won't be possible to cover every single type, but there'll be some ample time for question and answer. So the most important symptom that makes us think about Parkinsonism is when you have that slowness of movement. That's not just that you're moving a little bit more tired at the end of the day, you're shuffling now and then, but those repetitive movements that we do throughout our day get smaller and smaller as we repeat them. For example, your handwriting gets smaller as you go along the page. Your arm doesn't swing, or your arms don't swing quite as much as you continue walking. That's what we mean by the bradykinesia. And that's the most important symptom that we're looking for in Parkinsonism, that slowness of movement. We're usually looking for at least one of these other features for us as neurologists to say that you have Parkinsonism. This can include tremor, but usually when we're thinking about Parkinsonism, we're looking for tremor that's worse when the arm or leg is fully supported at rest. Usually gets better with activity. We're also looking for muscle stiffness, what we call medical terms rigidity. And it's something that you may experience as a tightness or actual discomfort. But on the exam, when we move the arms or legs around, even the head back and forth, side to side, we feel resistance. And it actually gets worse when we do things to distract you, like making circles in the air or opening the hand open and closed. The other feature that's less common in Parkinson's disease, but still a feature of Parkinsonism, is a balance problem where it's hard to catch yourself when you lose your footing. And if you've ever seen a movement disorder specialist like me or Dr. Evidente, you know we often will kind of have you stand up and pull you backwards and see if you can catch yourself with a step or two backwards. That's looking for that postural reflex. And that's often lost in someone with Parkinsonism. So overall, we're looking for at least 2 out of these 4 features to say that you have Parkinsonism. But then when we see the Parkinsonism, the first question is this caused by a degeneration in the brain or something else? And so we want to review your medication list carefully and think about whether you've been exposed to some of the antipsychotic medications or nausea medications that can cause Parkinsonism. We also may ask about occupational history, particularly if you had done a lot of welding in the past, which can cause Parkinsonism from deposits of the manganese fumes if you didn't wear your respirator. But if we don't have any other alternative explanations and you have very clear-cut Parkinsonism, then we start looking at the story. We're looking for the features, how everything played out, what other symptoms came along with the Parkinsonism, and which features came first. In particular, we're often asking about whether you have been told or thought yourself that you act out your dreams, because only certain causes of degeneration in the brain seem to be associated with acting out of the dreams, which can come sometimes years before any of the other features are diagnosed. Also common, mainly with Parkinson's disease, is a change in the sense of smell. Many people tell me they've never had a good sense of smell. And then constipation issues that can be present for many, many years before it's diagnosed. Now, as we get more experience and comfortable with the exam, many of us as specialists may only order the brain scans in cases where things aren't quite adding up. So if someone presents to me with a very classic Parkinson's disease, and there are no other features suggesting there's something else going on, I don't necessarily put them through extensive battery of tests and brain scans, particularly if they have limited insurance where there's going to be a lot of out-of-pocket costs that are not necessary. However, there are select cases where the DAT scan and also other types of brain scans can be useful. So the DAT scan takes a picture of the nerve endings in your brain where those dopamine cells project to and release dopamine. You can see on the left here what it should look like is a normal kind of comma-shaped appearance to those nerve endings that project to the motor areas of the brain we call the basal ganglia. On the right, you can see that shape is lost. And so that tells us there's been damage to those nerve endings. So it's a common pitfall is many doctors, even radiologists, will say that this test shows Parkinson's disease or is consistent with Parkinson's disease. And that's a little bit overly simplistic. What it does is it shows evidence to help support that there's a neurodegenerative cause of that Parkinsonism that we were talking about before. So the astute movement disorder neurologist will explain it this way, that now that we've done this scan, that tremor that we saw, we weren't sure what type of tremor you have, does look like, because it looks this way on the right, like it's due to degeneration in the brain. And now we have to decide if that degeneration is from Parkinson's or atypical Parkinsonism. So that's really on us to get the whole story and do the right kind of exam. That's the most common reason to order this test, and it's what it's approved for, is if someone has tremor that's there with activity, not just at rest. So it could be a little of both, or if you start with essential tremors, which is mainly there with activity, but then you develop a lot of rest tremor, it can be hard to tell if you really have the bradykinesia because the tremor interrupts the movements. And so that scan can be very useful to look for evidence of degeneration in the brain. It's sometimes useful also if someone's taking an antipsychotic medicine for sometimes not just for hallucinations, but actually for depression. And that medication blocks dopamine receptors. So if the Parkinsonism develops after you've been taking that medicine for a time, we may need this scan to help us decide if we need to talk to your psychiatrist about switching or not. Because obviously, if you had degeneration in the brain and loss of dopamine nerve endings that blocks dopamine activity, the antipsychotic could make that much worse. And so it's a tough conversation to have with a psychiatrist to have to change that around if it's working well for you. This scan can be very useful in those circumstances. Now, the other important thing that we look for to help us decide, do we need an MRI, besides just doing a thorough exam and looking for abnormal reflexes or other things that make us worry about, say, a tumor or a stroke, we're also thinking about whether the Parkinsonism is restricted just to the lower body. Because if just your legs have a problem and you feel like you're stuck in place when you try to walk or you shuffle when you walk, but your arms are working fine and there's no tremors, that might not necessarily be neurodegenerative Parkinsonism. And the DAT scan may not be necessary because we're already going to have our answer when we do the MRI or the CAT scan. And so the two main things we're looking for with that lower body Parkinsonism are normal pressure hydrocephalus and vascular Parkinsonism. So here's an example of what we're looking for with normal pressure hydrocephalus, or NPH for short. This is your brain. This is the front of your brain, just above the eyeballs. And this is right in the center, so we're looking across the brain, is these chambers in the brain that hold the spinal fluid, we call the ventricles. They're much bigger than they should be, and yet your brain, the brain of this individual here, doesn't really seem that shrunk. So those chambers will look large if the brain has shrunk because of degeneration in the brain or aging. But if these are enlarged out of proportion, and we'll actually measure to determine if it's out of proportion, large enough to cause symptoms of difficulty walking, that's where we say this could be normal pressure hydrocephalus. And what that is there's a problem absorbing the fluid, so it's not draining properly. And these areas around the ventricles are where the fibers are that supply your legs. And so if it's pressing on those fibers, it makes the signal hard to get down to the legs. And you may get kind of shuffling and unsteadiness when you walk. It almost looks, when we examine the person, it looks almost like a magnetic gait, like they're walking in metal boots on a magnet. So if someone has normal pressure hydrocephalus, placement of a shunt by a neurosurgeon where they put a little tube in here and then connect it to another part of the body, like the abdomen or the chest, that ventricular shunt can resolve the problem with walking. It may also potentially improve other symptoms of mild cognitive impairment, so trouble concentrating, trouble coming up with words, remembering things, and also bladder urgency. So if someone has advanced dementia, it won't reverse that because that's usually from a combination of degeneration, not just normal pressure hydrocephalus. But if the main problem is trouble walking, it could help. And how do we determine if you're likely to benefit from the shunt? Is we have to do a spinal tap procedure where we remove the spinal fluid, at least 30 milliliters of spinal fluid, and then see if there's an improvement in your walking afterwards. So a common pitfall is somebody will get sent and have this procedure, but then they'll just ask you, did your walking get better? And really, that's not a great way to measure it. So here's how we do it in the movement disorder clinic is we'll actually have somebody and we'll do a timed walk. So this is the woman whose scan I just showed you. And you can see she walks like her feet are glued to the floor almost. So that magnetic gait is what we call it in the chart. And then I had a colleague who does a lot of spinal taps, go ahead and remove at least 30 milliliters of fluid, and that'll take several hours to replenish. So we got to do this right afterwards. We'll go ahead and we'll repeat the tap. And you can see here, we've got people there for safety, but she's definitely walking a lot faster. And we actually do a timed walk, same distance, and measure that. So this is someone that actually benefited from from not just from the spinal tap, but actually from the ventricular shunt. And she didn't have any other slowness, stiffness in her arms that would point to something else. Unfortunately, many people can have more than one thing going on. And so people with normal pressure hydrocephalus may also have symptoms of Parkinson's disease. So tremors, for example, they may still need treatment for Parkinson's as well. And they also may have what we call the vascular Parkinsonism. So you can see on the MRI of this person, these bright areas are areas where there's a material called myelin that insulates connections between cells in the brain. We call axons, but they're really like telephone cables. So you remember back in the 80s, if there was a problem with the telephone cables, you get a scratchy phone connection. Well, here they get a scratchy connection if that myelin is worn off those connections, off the cables. And so it's, again, hard to get the signal down to the legs. And you can see a more dramatic example higher up in the brain. These are the fibers that supply the legs, and they're all worn down. We call this vascular Parkinsonism because they're very small blood vessels supplying those fibers. And so people who are genetically predisposed, especially if they've had high blood pressure in middle age, it's not well controlled, or a history of smoking, or both, they're much more prone to this problem. And this can cause really severe Parkinsonism. You can see this gentleman can barely get out of a chair without help and barely walk. And that was his MRI that I just showed you.
Hands with a belt make a great spotting tool. Just try to stand in place. Show me what happens if your legs start to bounce on you.
So really trouble getting those feet to go, and also unsteady on his feet. Unfortunately, the vascular Parkinsonism, if you don't also have Parkinson's disease as a factor, doesn't respond to the Parkinson's medications because it doesn't really improve the ability of that signal to get through to the feet. It's not due to low dopamine in the brain. Now, this is something that is really important for all of you to hear. If you have Parkinson's disease or you're being considered for a Parkinson's diagnosis, and your doctor is saying that they think you might have atypical Parkinsonism because you can't take levodopa. Now, one of the main features of the conditions I'm going to talk to you about next, the atypical Parkinsonism, where there's degeneration in the brain, is poor or waning response over time to levodopa. That doesn't necessarily mean intolerance to levodopa. There's a difference. If you take levodopa and you take even very low doses, but it just makes you really sick, that may mean that your body does a really good job of converting that levodopa to dopamine while it's still in your digestive tract where it can cause nausea. The reason carbidopa is in there to prevent the body from converting it too soon to dopamine where it can cause nausea in the gut or dizziness if it's still in the bloodstream. So one approach we'll often use is we'll just start you with very low doses, like half or quarter tablets once a day, and then work up to twice a day in a week or two, and then 3 times a day after that. But we'll work your way up much more gradually. If that doesn't work, we still got other tricks up our sleeve. We may, if you can afford it and your insurance agrees to cover it at an affordable price, give you carbidopa 25 milligram tablets with each dose, which may help prevent that side effect better than the amount that's in the pills. Unfortunately, most insurance doesn't cover it well, and it can cost hundreds of dollars a month. So we sometimes will have to try and find a nausea drug that won't block dopamine in your brain, and there are very few options that actually work well in this situation. One of them, there's a national shortage. It's called Tygan or trimethylbenzamide. There's another one that in all the other developed countries of the world is widely available, except the United States, called domperidone. But we don't yet have it approved here in the United States. And so we sometimes have to order it from Canada in order to help someone tolerate their levodopa. But don't let someone tell you that you have atypical Parkinsonism unless they've tried all of these tricks. And if they don't know what you're talking about when you bring this up, please get a second opinion with a movement disorder specialist. Another important problem, some people, after they take their carbidopa levodopa, they have this brain fog, or they just fall asleep when the medicine starts to kick in, because the immediate release tablets kick in really fast for them. They do a really good job of absorbing the medication. And that has to do with getting it to your brain too quickly. And so we may switch you to a slow release tablet if that happens. And that often mitigates or gets rid of that problem. So again, if your doctor doesn't know what you're talking about when you bring this up, they're probably still familiar with the slow release pills. So you might want to talk to them about giving it a try. Don't try and do any of this stuff on your own, but talk to your doctors and take home the information that you're getting today and see if it's relevant to you after talking with your healthcare professional. So the important thing when we're seeing that things aren't quite adding up is we're asking for other clues that might point away from run-of-the-mill Parkinson's disease. One of the most important features would be if you're not responding well to Parkinson's medications, even though we've taken measures to help you tolerate levodopa. The other would be is if there's early severe impairment in memory and thinking, enough to interfere with everyday activities. If there's very early problems with hallucinations, if there's dramatic fluctuations in level of attention and disorientation, that might make us think about dementia with Lewy bodies. If there are very serious falls that are unprovoked, not just because your pets ran in front of you or you couldn't figure out who's walking whom, but you actually fell just because you lost your balance and it's happening on a regular basis, if that happens in your very first 3 years, that's a big red flag. It could be one of the atypical disorders. Also, if you have trouble moving your eyes in the vertical direction, that's also not typical early in the course of Parkinson's disease. Early severe problems with a drop in blood pressure when you're standing up is not typical for Parkinson's either, unless you're taking lots and lots of blood pressure lowering medicine. Sometimes we have to back those down and see if that problem is still present. And if it is in your first 3 years, that's another red flag that makes us think, wow, this could be atypical Parkinsonism. And these are the common reasons where a general neurologist with a lot of experience with Parkinson's disease may consult the movement disorder specialist, is to sort out these unusual cases. So, I put together kind of a table here just to give you a sense of all the different things we're looking at and what are the conditions that are most likely to cause what. And one thing I want to kind of bring back to you is I mentioned REM sleep behavior disorder earlier. That's where in the middle of the night when you're having an action-packed dream, you may act it out. You may jump out of bed, hit your bed partner, strangle your pets, because you're dreaming that you're protecting them from an intruder, but you're actually attacking the person next to you. And that is REM sleep behavior disorder. And that happens on a recurrent basis in Parkinson's disease, but also in multiple system atrophy or dementia with Lewy bodies. It's very unusual in these other conditions, though it rarely can occur in a subtype of progressive supranuclear palsy. One thing we don't have is we don't have a way to actually take a picture of the brain and see what are the deposits that are causing your symptoms. The only scans we have available right now, they mainly look for the deposits that cause Alzheimer's disease, like the amyloid plaques. But we don't have a scan to look for the Lewy bodies of Parkinson's and dementia with Lewy bodies, or the other deposits that these other conditions have. So that's where, brain donation, and we have a brain bank that we work on with Mayo Clinic over at Banner. Anyone can sign up that's in Maricopa County. Signing up to donate your brain will help people down the road by helping us learn how to develop these tests. It will also give your family a definite diagnosis which condition you had, because the symptoms I'm telling you about tonight aren't fully diagnostic. They're just clues that, if you have all the main features, make us fairly confident this is what you have. But it's never 100% without seeing the brain under a microscope. Now, the term Lewy body dementia is a term we use to make it clear that the problem with memory and thinking is related to Lewy bodies that are deposited in the brain. But it can be in advanced stages of Parkinson's, you have dementia, or it could be if you have dementia in your very first year of symptoms. But that type where the dementia is present very early, we actually call dementia with Lewy bodies. And that one has some other features. First of all, there may be profound fluctuations in your level of attentiveness or alertness. The Parkinsonism is a core feature. Not everyone has that with dementia with Lewy bodies. Recurrent visual hallucinations, and then the recurrent dream enactment. And so if you have at least 2 out of these 4, that makes us very confident that this is dementia with Lewy bodies. If you don't, then the DAT scan may be useful, particularly if you don't have very clear-cut Parkinsonism. And having that DAT scan is another important clue. Also, if we're not sure if you have REM sleep behavior disorder, a sleep study looking for specific features of REM sleep behavior disorder can be useful, but only if it's done by a neurologist that understands what the doctor's looking for, because most sleep doctors won't comment about the things that we're looking for. So it's important that if you have Lewy body dementia, either from Parkinson's or dementia with Lewy bodies, that we really avoid most antipsychotics for hallucinations. Even though doctors often prescribe olanzapine if someone's really out of control, we won't want to use that long term because it can really worsen motor symptoms of Parkinsonism. We usually will use the quetiapine, or the prescription that's FDA approved is Nuplacid, known as pimavanserin, because quetiapine or Seroquel and Nuplacid are less likely. They don't really show evidence at the doses we commonly use that they don't worsen Parkinsonism. So Nuplacid doesn't worsen it at all. Seroquel at the doses we commonly used does not worsen Parkinsonism, and it's less likely even at higher doses. Now, for those of you who are old enough to remember, this actor was starring alongside Bo Derek in the movie 10, but he also played an alcoholic millionaire in the movie Arthur. So I wasn't allowed to stay up to watch this movie when it first came out, but the new version of Arthur that was actually about the alcoholic billionaire. So Dudley Moore played the original. This is Dudley Moore when he was first starting to have some symptoms of his illness, where he was forgetting his lines, and Barbra Streisand had to let him go from the set of The Mirror Has Two Faces. And here he is much later in life as he's developing neurological symptoms. You can see when the Queen actually made him a knight, he wasn't able to show how elated he was because he was having these muscle spasms in his face. And This is because he actually was being diagnosed with progressive supranuclear palsy. He never lost a sense of humor, though, since it's a very rare disease. He thought it was really magnanimous of him, since it only affects 1 out of 100,000 people, that he accepted this fate for himself and protected the other members, other nearly 100,000 members of the Screen Actors Guild from this fate. Now, PSP is something that usually causes early severe falls, but it also impairs the ability to move your eyes up and down, so to look vertically, and it causes atypical Parkinsonism. Later in the course can cause swallowing problems, but even early on can cause a frontotemporal type dementia where there are problems with language, and some people even get very impulsive. This is an example of someone with PSP. You can hear it has a kind of a gravelly pronunciation problem with his speech and trouble moving his eyes up and down and severe balance problems.
Yes, I fall. How often do you fall? Every day. Do you trip on something, or is there something that makes you fall? No, I just fall. Just lose my balance and fall. And you don't stop there. You follow it with your eyes.
So he can still look side to side, but then we have him try and look up and down. And it just can't do it. And some people, they're slower in their eye movements up and down, but they can still do them to some degree. We also on the MRI can see specific features with PSP, and there's a thinning in this part we call the midbrain that we're looking for on the MRI. So the MRI is also useful if we're looking for specific features of an atypical Parkinsonian disorder. There's another condition that can cause a different appearance. There's something that looks like a plus sign we call the hot cross bun sign. And then there's also this atrophy in the part of the brainstem called the pons. This is a condition called MSA for short, multiple system atrophy. And with this condition, there's usually an early problem either with autonomic nervous system or with the coordination center of the brain, the cerebellum. And so if somebody, even though we take away medicines that might be contributing, they're having severe drops in blood pressure when they stand up, and their Parkinson medications aren't working as well as we'd expect, or they're losing benefit, then we would diagnose multiple system atrophy. We would also do so if we saw they mainly had severe coordination and balance problems. One important clue is we're also looking not just for drops in blood pressure, but also for bladder incontinence. So with atypical Parkinsonism, it is a more rapid progression than what we typically see with Parkinson's disease. So this is an important diagnosis for us to be upfront about when we're considering it, because people aren't always prepared for this rapid progression. Most people with these atypical Parkinsonisms become wheelchair bound because of their gait and balance problems within the first 3 to 5 years. This is the average. There are people that break the rules. And on average, they live 7 to 8 years from when the symptoms start. We've met many people with Parkinson's who are still alive 20 years after they were diagnosed and going strong. That doesn't happen with the atypical disorders. There are rule breakers that still live past 10 years, but it's rare. And there are people that even progress much faster. And some people do respond to the levodopa somewhat, but they may require much higher doses, and the response may really decrease, wane over time. So it's important that we still ask about all the other symptoms that could have treatments, like sleep problems, mood and anxiety problems, bladder control issues. Even constipation is an important symptom to ask about and to address. And one of the most important things you can do if you're being considered for a diagnosis, not just of Parkinson's disease, but atypical Parkinsonism, is to make sure that you've got all of your care team coordinating your care together, and they're copying each other in on their reports. They're communicating if they think medications need to be changed. And very often we'll have a cardiologist involved in people with the autonomic problems, or urologist as well. And we'll have physical therapy, speech therapy, occupational therapy, and social workers involved to give you the therapies that you need at each stage of the illness, but also to help you plan ahead, especially with social worker, so that you're prepared for each stage and you're able to cope with things as they come up and not being reactive and instead can be proactive. So that in a nutshell is how we approach atypical Parkinsonism. Really appreciate your attention and your having me tonight. I'm going to discontinue the screen share now, and then we're going to go through some of the questions and answers.